I'm going to present a real flame patient, and I was very honored to be part of this important study. This is a 69-year-old female with dyspnea and syncope. She has history of hypertension, CKD stage 4, and recently diagnosed Graves' disease. She presented very short of breath and dizzy. And in the ER, she was given oxygen because the saturation was barely 80% and her blood pressure was 70/40. IV fluids were given, blood pressure continued to be less than 90. She kind of looked thick. Then they started epi-drip. Systolic blood pressure was around 100, heart rate 120 to 130. So by all means, she's a sick patient. And we still don't have a diagnosis of PE on her, but obviously I'm presenting her in this talk, so she's going to end up having PE. But that was the suspicion at the time because the RV was big. And then the ER physician had point of care ultrasound, which is great. They could find also a suspected clot in the right femoral vein. So no CT was done because her creatinine was elevated. And at this point, the PE team was called for this patient. So here I'm going to focus on the workflow of why this, how this happens, because a lot of the discussion sometimes hinges on how easy is it or how fast can we take those patients that present with high-risk PE to the cath lab, and is this something feasible when you're trying to do a procedure such as FlowTriever aspiration thrombectomy? And so basically our workflow goes this way. The ER physician calls PERT, and heparin was started at the same time. And PERT could be maybe, it depends really on what hospital you're working in, and it's very variable in different centers. The PERT might be the interventionals on call all the time. It could be a fellow in an academic center. It could be a medical doctor. But either way, eventually the call gets to the cath lab attending. And the cath lab, which was attending, which was myself at that time, and my fellow, we went immediately to the ER to see the patient. And then we saw the patient. We discussed briefly with both the patient and the ER physician. She was on epinephrine, and we talked about, we don't have a clear a sure diagnosis, but we think it's most likely a PE. And instead of giving lytics, which is done frequently, maybe in other centers in the ER with this patient, we can take the patient to the lab both for a quick diagnosis and for thrombectomy. So this reminds me of what we do many times for STEMI or for cold strokes or for other emergencies. We are available for these emergencies, and interventionists are used to bring the patients up to the lab. The other thought here is that the ER physician actually I was talking to told me, okay, so he was a new physician, was not like very used to what we use. And he said, okay, then what do you think about pushing lytics? And if this ER physician would have done maybe a CT scan and saw the PE and did not think about calling PERT, that same ER physician would have pushed lytics on this patient. And this patient would have been in the context arm that Mitch was talking about earlier. And that's how the flow went with this trial, and that's how the flow usually goes with these patients in our hospital. Now, the patient was consented quickly, and she was taken to the cath lab. In these sick patients, I don't give them sedation. I put arterial sheath, small 4 French arterial sheath, just in case they need extra support, ECMO, or also to look at their blood pressure during the procedure. And obviously went through the right femoral, in her case, I think we went through I'm sorry, this is a mistake, left femoral vein, went through the left femoral vein because she had clot in the right. And we did a quick right heart cath. The numbers were as expected, RA15. Mean PA was 32. Notice that these patients cannot generate a lot of pressure in the lungs. So she's not going to have a mean PA of 60 or 70 because she's an acute PE. And her cardiac index was 1.6 on epinephrine. And notice that during the procedure, I was giving her occasional boluses of norepinephrine. Now, one can argue that this patient should be thrown on ECMO at that time because of her impending arrest, because she's getting doses of norepinephrine. But here where my thought is that if the patient is able to be stored until we get something up in the lungs, and until we suck the majority of the occlusive clots, then the patient will improve immediately. This is an obstructive shock, and the key is to remove the obstruction. If we can do it quickly as the patient is there on the table, then I think that's the best course of action for the patient. Now, that being said, if you really think that you're unable to continue the case and the patient is really going downhill, then you may want to throw the patient on ECMO if that's available to you in your cath lab. So what we did is we went up with a catheter here, shot the right lung initially, and in patients that you suspect kind of a massive PE and just a manual quick injection of 5 cc's of contrast, you should be able to see what you need to see. And that right lung was a little surprising because I expected it to be more occluded in somebody who's in shock. But I think the issue is that some of it was occluded, but the left was totally occluded. That's why she was not doing well. And sent out with the flow retriever to the right lung. We pulled a few macerated clots, not a lot, as this picture shows. But then on the left, we pulled some clots initially, and then the catheter was unable to pull more, but it was corked at the tip. So the vacuum was still inside the catheter, and we pulled that catheter down to the IVC. The reason I'm showing this is that this doesn't happen a lot in this procedure because in acute cases, many times the catheter is big enough to aspirate either a total or partially macerated clot from the lung. But in some of the cases, the clot keeps dragging down into the IVC. And when I get down to the IVC, I shoot the contrast through the sheath to see what's going on at the tip of my catheter. And the reason I'm having this picture here is to notice a couple things. Number one, notice how big that clot is that's obstructing, but also notice that this thing was able to be dragged in total, hooked up to a catheter that's half its size, and hooked and gone through angles in the left lung, in the heart, and through the IVC. So it tells you that this is an organized clot. So which tells me that patients that go in shock and have acute presentation with massive PE or high-risk PE, they don't necessarily have that friable, very fresh clot. This clot had been sitting in the femoral veins for a while before it traveled to the lungs. And I think these are the patients that may not respond always to lytics when you give them, or it takes much longer for the lytics to work because of the organization of this clot. In my mind, that's why if we're able to take this out as soon as possible, that's the best thing for the patient. And in these cases, it doesn't happen to me a lot. Maybe I've done a lot of flow retriever catheterization, and maybe I've seen this about maybe 5 times where I drag a clot down to the IVC. I put a filter from the other side and then drag the clot out. And then if there are any clots left in the filter, I go after them and take them out with the same flow retriever. Usually straightforward procedure there. And the filter was clean after that. So these are the clots that look partially organized. Notice that some of them are acute, but not that acute. Obviously, they were able to be removed all in one clot and one mass. Now, post-procedure, she was really doing well, like the case that was presented by Jay. Systolic blood pressure went up above 130, pressors were weaned off, heart rate less than 100. Her PA pressure went down to 26, which is obviously, this is now old story. We've seen that a lot with FLASH, how the PA pressure drops immediately, and the cardiac index improves with the procedure. It's interesting that the calculated cardiac index never goes up a lot. It goes up a little bit, but that frequently puts the patient really away from that precipice that they were in. And I wonder if sometimes our calculation of the cardiac index is not very accurate because the oxygen consumption might be different in these patients as they're sick and they're less sick. But anyway, this patient went home also 3 days later, and she did well. So that's what I have as a case, and we can go into discussion. I just want to mention one thing because Mitch, with what you talked about earlier about criticism and this with this procedure and taking patients to the lab, some of the things that we heard is the fact that sick patients with low cardiac output may not tolerate a big catheter going up through the RV and the PA. And I mean, there's maybe some truth to that, but in my experience, the majority, and I'm sure probably you guys can help me with that, and majority of the patients, all the patients that I've taken to the lab and got a flow retriever up to the lungs, they tolerate it. I mean, if they're very sick, every now and then, like this patient, you may give some boluses of pressors, just temporarily. And this is a fast procedure if you're used to it. You go up and take the clots out of the lungs. So the main lesson that I take out of all this is that if the patients, you think you can take them to the lab and you're able to go to put them on the table and you can go up quickly with the flow retriever, they do well. They do well. They improve quickly and they tolerate the procedure. That's a main thing that I get from this. The other thing is The other criticism, because that question I wanted to answer that Mike has asked, is criticism that we hear about this is that, well, this is just a niche procedure for a niche community that's used to doing this, and it cannot be generalized to the community. And I have to say that actually this procedure is not difficult. Now, it's not a procedure you want to do when you have not done many of before, when the patient is massive, when the patient is sick. But if you've done several of these on patients that are intermediate risk, I don't think there should be much in terms of learning curve to be able to just use it on any sick patient. And it's not really a technically challenging procedure to expand. Most of the time, it's a case selection that actually kind of is the most important point here. Is who is the patient to go to the lab, rather than what technique is being used. Technique has been really straightforward and has been standardized so far in these catheterization.